what we've learned, and I'll tell you more about what I've learned, and then you can share some of your takeaways. We really had a variety of presentations here and perspectives, and I want to make sure that we can get your perspectives and learnings from this as well. So please feel free to comment, raise your hand throughout as you see something that you wanted to remind us about or let us know. But so we started yesterday, and we broke out, and these are the sessions that we did yesterday and today. We looked at third-party QC, uncertainty and traceability, assessment of competence, Six Sigma, quality indicators, quality assurance, external quality assurance, frequency of quality control, accreditation, QC in qualitative and semi-quantitative environments, and point of care. A lot of activity. We did a lot in the last 2 days, and our heads are probably full. Some of it was maybe new and novel for you, some of it not as much. There were some themes that came across. We talked a lot about people and the importance of sort of education of our staff and in the assessment, whether it's the assessment of competence, whether it's education of clinicians, and sort of the difference between methodologies. I don't know if this is a question here for us, or if this is reminding us of how we answered yesterday. This is how we answered yesterday. 85% said they do use third-party controls every day of testing. That actually was a surprise for me. Was it a surprise for people in the group? No? So in our third-party control segment, we also learned how to hunt ducks, right? And on average, the duck is dead. Thank you, Oswald, for that wonderful. And then we started the day with a cartoon that showed that laboratory personnel was the most important aspect in quality control. And I thought that was very fitting for Dr. Goldschmidt, and that became a theme that was pervasive throughout the 2 days. I was also encouraged, Dr. Goldschmidt, about you encouraged us to sort of enlarge the span of third-party QC, but doing it in a transparent way. He said, what would Google do, right? And so that sort of set some context for us. We also talked about uncertainty and traceability. And one of the things that I got from this session in particular was the difference between the result and the measured value, and that the sort of the need to attach that uncertainty to be a measurement result. And that was a distinction I hadn't really thought about before. Callum?
As we talked about yesterday, this is really still incomplete without some mention of the probability, the coverage factor, and that the plus or minus 0.2 can be interpreted in a variety of ways. And I would put it to everyone that the measurement result, the measurement certainty is included, but so must the meaning of the uncertainty in terms of the probability.
Anybody want to add? Okay. So then Graham Jones helped us think about this and sort of what is our role in communicating that information to the clinicians. And we did some polling, and we talked about that we found that we really do need to educate the physicians about the meaning of this and what do they do with it. So last year, this was the results of the question, uncertainty should be reported routinely with each test result. The sentiment was that the group disagreed or strongly disagreed. And this year, slightly different tweak. It said providing data about uncertainty would. And we had probably improve and create more confusion. I think we asked this before you spoke. I'm not sure. We talked about personnel competency, and Dave Burnett was not able to be here with us, unfortunately, and Mario gave his presentation. One of the things that I took away and noticed from it was a great conversation, and we had some some good back and forth, I got hooked, or I took away something from this idea of how do we encourage productive working relationships, and this need for leadership development, management skills, the soft skills part of the work that we don't maybe often think about. Pamela from Scotland also asked about what about those who are, those who are entrenched in sort of their old ways and not so much open to personnel, to competence and direct observation, competence evaluation. And we had some conversations about that. Mm-hmm.
What I missed in this respect is lean thinking, because in my lab we are now 5 years on the road, and it wakes up people, even people who are 15 years on board, and especially when you do video and you show people how they do the job, you can real empowerment, and also continuous improvement by Kaizen. And not a week, but a daily Kaizen of every employee wakes up people. So maybe next year, more lean thinking.
Good. Great. So we talked about quality specifications, and we talked about this idea of maybe a fourth level of specifications. And one of the things that I was encouraged by was that this was some of the work that was done at the previous working groups and previous experts meeting and convocation, and it was continued. And there were several presentations throughout the last 2 days that hit on that. Graham was one of them, and there was another today, as well as this quality specifications, that sort of shows how, as a community, when we get together and share and sort of continue the work, we can have some sort of novel conclusions. We learned that the database, the 1999 I think it was the original year database, continues to be updated. Added 45 new analytes, and continues that work. Talked about Six Sigma and Sigma metric indicators, Sigma performance indicators, and Natalie shared her experience at Unilab and how it enables them to have a full view of the performance of their system. I asked also to the group about, is this something that can help in communicating to top senior management easily about the quality of the laboratory? And maybe it can help in making those sort of financial decisions that we think that senior management is often want to do as they're thinking about reducing costs and things like that. So, and then Jeremy encouraged us to think about coming up with some harmonized way of calculating the metric. And one of the things that I took from this was that there was this statement about CV values are not transferable, but the sigma values are. And it kind of put a dimension around how you can use this in looking at the relative quality of your analysis. This was interesting from Julian. Julian talked about the study that was done by a non-laboratorian I asked him afterward if he felt that this person really understood the laboratory, and he said absolutely. So in this idea of quality indicators, there was some work that was done and really understood the laboratory. And so we got into a broader discussion yesterday about all of the different quality indicators that are out there and all of the efforts. We heard that there's 69 indicators coming out of China. There's a number that Mario and his group have done. There's some in Brazil. And how can we get to some kind of harmonization? And one of the suggestions was to have local champions. So you might have an indicator that works well in your particular area and well in another area. We have local champions that can develop those, make it work and fine-tune it, and then we can look at harmonizing and sharing. We had a session on EQA and harmonization in EQA, and one of the things, and it's not necessarily on here, but I'm a believer in 17043 accreditation for EQA programs, but I also really took note that it was recommended that it's not a panacea. I agree. It doesn't solve all of the problems with the variation in EQA programs. We also talked a bit about EQA being a real tool for quality improvement, and I encourage each of you, if you think about this and you want to be involved in this, the CLSI GP27 standard and guideline that talks about how to use proficiency testing in an educational and sort of quality improvement way. We asked this question, and half of you, more than half, agreed or strongly agreed that it's a problem that EQA programs are not accredited to international standards. So then we got into a discussion about the frequency of QC. It was near the end of the day, and we were ready for dinner, but it's a really interesting topic. We actually had a few questions before this that were sort of enlightening for us. But Niels took us through some of the current sort of work that's been out there and in the journals, et cetera, kind of introducing Kurt. And what we started to talk about was that, you know, we know a lot about how many controls to run and what rules to use, but not so much about how frequently to do that, when. And so Kurt shared with us this model, and we've seen this in a number of papers that he's done that shows sort of the number of patient results that could be affected when a shift happens in the process between control events. Interesting, the audience, and I think we have it here, this one, this was an interesting response, I think, that 58 plus 17 disagreed or strongly disagreed that the cost of patient care can be reduced by increasing QC frequency. That was surprising to me. Anybody have a comment about this? No? Anyone, any of the agrees want to say why they've agreed? Yep, Niels?
I think we simply lack the evidence.
Mm-hmm.
And as I said yesterday, it's striking how many trivial reasons for mistakes you will still find in even accredited environments. And we have heard some more examples of that today. So I think it's a quite important question, and it should be worthwhile studying it. But at the moment, it's just a guess.
Right. Okay. Graham? Run, Andy, run.
If I could comment just on the wording of the question, it implies that if we think we could do better by doing more QC, which means that we then think we're not doing it right at the moment. So if we believe that that was true, we should have already fixed it by running some more QC. Now, so if that refers to our individual labs, if I agreed, then I should go home and change it. But I think we're doing it reasonably, although Niels's point that we may not know the effect that comes out of it. So what we might be just saying there is we think we're doing a good job.
Okay. Jeremy.
I think this question here are overall cost of patient care, you know. It's something that is really, really difficult to evaluate. And I think it's really a job of professional people, you know. And there are people doing that all the time. Just to give you an example, previously we've been doing some kind of pharmacoeconomic study, you know, with the implementation of a new drug in transplantation for transplant patients, just to evaluate the cost reduction in the overall care for the patients. We had to have one specialist in pharmacoeconomics work full-time for 3 months, just for 50 patients. So I think estimating the overall cost of patient care and the reduction or potential reduction by a change in the QC practice, we can do that, but it's really, really complicated. And maybe for the next meeting, we can have some expert coming to talk about that, you know, because there are some people doing that right all day long in many, many countries because cost is so important in healthcare.
Yeah, I think it's interesting that in this group we very much we're into the semantics of what the question is asking, and can we really quantify that, because that's what we like to do. We like to quantify things. We like to verify things. It's very much it wasn't so much. I thought of this as sort of a gut reaction kind of thing, like it was a thought that it might be intuitive. It was something like that, and it's interesting to hear that. Well, you know, there's a lot of analysis that needs to be done there. It's true, there is. In 2011, we asked this about how frequently you test your QC materials. And yesterday, mostly the same wording, but not exactly. Let's go back. But still the majority response is the same. So number 4 here is the same as number 4 there. This was 2011. When we look at the wording, we said when an out-of-control error condition occurs, the laboratory should retest all patient samples since the last successful QC event. And it was sort of interesting, right? Agree, disagree. 38%, 41%. And yesterday, we asked when an out-of-control condition occurs, the lab should retest patient samples since the last successful QC event. It didn't say all patient samples. And it was pretty much the same. At dinner, I talked with someone about how they read this to say when it would be different when they found out it was a sort of a real out-of-control error condition, right, as opposed to just a flag. So we started to talk about accreditation today, which is an area close to my heart, and it's interesting to put it in context of risk. So risk is really coming into the accreditation standards, especially in ISO 15189. It's also coming into some of the CLIA rules in the United States. And it's very interesting to look at some of the data on accreditation. I didn't remember that 75% said that they were accredited in 2010. In fact, I'm not sure that I believed that that was really true. But we didn't specify at that time to what standard or what that meant, right? I remember being at a meeting at this time, not this meeting here, but in Latin America, and somebody from Chile said that there were 700 accredited labs in Chile, yet they didn't have an accrediting body that was functioning and it wasn't doing so. It was just sort of some perception that was out there. In 2011, so again, it didn't specify the standard. So 2010, 75% said yes. 2011, 61% said yes. But people were considering it, people were working on it. In 2012, we specified the standard, but we have 80% saying that they're accredited. So this was a really interesting session for me. It's an area that I don't have much expertise, but I've been thinking about for our customers and for our company sort of what about this gap in information about how to do, where to get resources and what to confirm against in quality control planning in semi-quantitative and qualitative QC. And so I was really encouraged by the two presentations this morning about that. In particular, all the work that's being done in Israel, and really she's having to develop that based on the individual situation that she's faced with. And in the Netherlands, in Anne-Marie's case, taking the EP23 sort of risk document that we discussed at this meeting last year, and it's only been out since October or so of 2011, and sort of putting that into practice in her laboratory. And she says something really telling at the end. She said, this is the why. This is the why we're doing what we're doing. This is the why we're doing the QC that we're doing. And I think that's a key point. So we talked about point of care in our last session. And Professor Lippi was very dynamic and very fervent about the subject. Both of them, great presenters. I'm interested to find out about, he talked about the point of care standard 22870. And it recommended that the laboratory should have control of point of care testing and some other things. Anybody have an experience in using the standard 22870 in their point of care setting? Niels?
Well, as it is an ISO standard, there's quite some overlap in the managerial requirements with the ISO 15189. Fortunately, so the main issue for an accredited lab is in the technical aspects. They're quite logic, and what we use the standard. We are not accredited against the standard. I don't know whether that is possible or not, but anyway, it gives us a lot of guidance in how to organize it, and it's also very helpful in convincing other parties in your environment in the discussion on how to organize things concerning point of care testing.
Good, thank you. There's a question in the back, comment in the back.
My lab just passed the CPA for the new standards, and the three challenges that we have faced was first the method comparison lab to point of care. The second one was the competency, and the third is the connectivity. And I believe in terms of connectivity, if it was big hospital setting, it will be quite expensive and difficult to achieve the standard for CPA, but my lab is very small, and that wasn't a problem, to have connectivity for most of the devices. For the competency, we adopted on system for blood transfusion, and it was semi-electronic and paper system, and that passed with a flying color. The method comparison, just we needed to drive our own specifications, which the difference, the comparison between the lab and the point of care method. And at the end of the day, we passed.
Good. Andy, on the aisle.
This is just more of an observation or a question, I suppose. But I know we talked earlier on about the manufacturers providing training and competence, potentially competency assessment. But the gap that I've always struggled to bridge is that when you are introducing a quality management system to point of care, training the users in that as well, and I don't know if anybody's got any experience in that, because I know it's, when we kind of reintroduce quality management into our lab, training people is still ongoing now, and convincing people that it's a worthwhile exercise is an ongoing process. And so starting that with end users of point of care devices, I'd be interested to hear if anybody's got any experience with that, really.
Yes, we in our laboratory we obtained the accreditation 22870 for POCT, but only for glycosylated hemoglobin, and we are working to obtain the same accreditation for blood gas.
Okay. I was.
I think there's a crucial point, the definition, exact definition of what is a POCT, because if we consider blood gases, if we consider glucose meter, it's not the same technology, and do we use quality control to test strip or to test the device? This is it's easy to understand that in blood gases we have the same reagent. Even if we use cartridges, we have the possibility to check the apparatus, the device. But in case of strip, I think the notion of the quality control applied to a lot of in a lot of reagent could be more stringent that to test the strip only. I mean that we need to define more precisely POCT because the same rules couldn't be applied to the same kind of device.
So the paper, I forgot the author, but the paper sort of had identified a couple different point of care sort of definitions that, you know, cartridge and then you have strip and things like that. So that's an interesting one to look at and maybe could flesh out some more. I was interested in Dr. Nauck's talk about the Relibac and the point of care device is saying, you know, one control a week. And we just encountered that in the US about sort of where would some sort of a determination like that come from, and it could be different based on different devices. And the US regulation on that is changing now, and it's going to say that the laboratory can determine, and it must follow manufacturer's instructions at the minimum, but the laboratory needs to determine its quality control, its external quality control, external IQC, say liquid control strategy, based on a risk assessment, based on the EP23 risk assessment. So you need to look at all of the factors in your laboratory, upstream and downstream, that could impact that. So same device, laboratory A and laboratory B may actually be assessed. The same assessor would say that that's appropriate for this laboratory, but something different is appropriate for this laboratory based on their situation. So that's going to be an area of all kinds of work for the next years. Yes?
Speaking about software of quality control, we find that point of care blood gases has his own software of quality control, but from my point of view are not as good as, for example, Unity. So have you working make connection since middleware of blood gases to Unity system? Because it has a lot of tools we can use easily from lab.
Yeah, I can't speak exactly to that about the Unity, but I can get the answer for you. Yep.
We have experience on that. Off-site, we can provide you some information, for sure.
Graham?
The risk management approach you described sounds very interesting. As an alternative to the Relibac, where a single-use device being tested once a week, the Australian standard for workplace drug testing using disposable devices is that you need to run a high and low control at least every time that it's used. Part of the rationale for that is that the location where it might be is at a mine site or a train station, and those devices might be carried around in various things in different temperatures. So they've set up the standard is set for, if you like, the most variable circumstance, even though the same device may be used in an office, for example, of a pilot before they're going to fly.
Yeah.
Obviously, the other part about risk management is the consequences of that test, that someone might not be able to do their work, or alternatively that someone might do their work in an impaired state. So they've gone for a very high level of QC for that.
Good. Okay, and that was one of the questions we had. So for me, this was a fantastic 2 days together. I really appreciate the camaraderie. I appreciate the exchange of ideas. The input from you all. All the presentations were excellent. Thank you for putting the time into that. We had 22 presentations over the 2 days on 11 subjects that are all very important to us all. We've seen an evolution in the way we've been thinking about some things. We've seen some things reinforced, And I'm very excited that the work that we have been doing over the last couple of years continues to sort of pay forward in what we're doing back in our laboratories. So I truly thank you and thank Gianni and Lucia and the team for hosting us here, and wish you safe travels home.
Okay. Since as yesterday I opened the works, and I'm proud to close this work. Thanks, Max, for sure, for the excellent job you did. But thanks to you all for the profitable, productive, and professional help in getting this meeting very successful. Thanks so much. And don't forget the certificate of participation outside the room before you're leaving. And have a nice flight or train, or in any case, travel back home safe. Okay. Thank you.
The devices.
And the devices, correct. So please return the device. It's easy to forget in the pocket. Yes, thanks for reminding that for Dr. Bernabeu, the blue card, if you can return to the registration desk.